Okay, well, thank you so much, everyone, for joining us for the webinar, Bladder Cancer Treatment, Potential Side Effects. I'm Teresa Blondin, the National Volunteer and Program Manager here at Bladder Cancer Canada, and I'm honored to be facilitating this session tonight. I'm so happy that you're all joining us to empower yourself through knowledge. At Bladder Cancer Canada, we believe that education can help facilitate and increase quality of life for people affected by bladder cancer, and that's why we host webinars like this. So before we dive in, your mics and cameras will remain off for the duration of the session. However, we'd love to know who's here with us today. So if you're willing, please drop your name and location into the chat. Please remember that webinars contain content intended for the sole purpose of information sharing and should not be considered medical advice. Always talk to your doctor or urologist about what is best for you. There will be time for a Q&A session after the presentation, so please type any questions into the Q&A section, which you should see at the bottom of your screen in the Zoom control panel. Sometimes it can be along the side or along the top, depending on your computer. We'll answer as many questions as time will allow after the presentation, and please use the Q&A option today instead of the chat box for questions. And remember, when formulating your questions, please keep in mind that due to the complex and unique nature of each patient's situation, the doctors cannot provide specific medical advice. And if you run into any issues, myself and my colleagues, Shasa Boshoff and Emma Ray, are monitoring the chat and happy to help. So now I'm honored to introduce our presenters for the night, Dr. Ross Mason, Dr. Peter Chung, and Dr. Lori Wood. Dr. Mason is a urologist and urologic oncologist in Halifax and assistant professor of urology at Dalhousie University. He's also a member of our medical advisory board, and he will cover localized therapy. Dr. Peter Chung is a radiation oncologist, associate professor in the Department of Radiation Oncology at the University of Toronto, and a clinician investigator at Princess Margaret Cancer Centre. He's also a member of the Canadian Bladder Cancer Research Network Steering Committee, and he'll cover localized therapy focusing on radiation. And Dr. Wood is a medical oncologist at Queen Elizabeth II Health Sciences Centre in Halifax, as well as a professor in the Department of Medicine at Dalhousie University with a cross appointment in the Department of Urology. She's also a member of our medical advisory board, and she will wrap up the session with systemic therapy. So thank you so much, Dr. Mason, Chung, and Wood, for giving us your time tonight. And I will pass things off to Dr. Mason to kick it off.
Well, thank you to Bladder Cancer Canada and to all of you for the invite to be here. It's a wonderful organization, and I'm happy to give this talk. So I am going to talk about the toxicity and potential side effects of local treatment, that's treatment to the bladder, specifically focusing on TURBTs, BCG therapy, and bladder removal or radical cystectomy. These are my disclosures. So what is a urologic oncologist? So I'm a urologist with specialized training in cancers of the urinary and genital systems. And so bladder cancer, kidney cancer, prostate, testicular, and penile cancer. And a large part of my job is in performing surgeries for these cancers, but I also play a role in the diagnosis and also the management of side effects and complications and providing supportive care to patients with bladder cancer. So bladder cancer, as many of you know, is common. It is the 5th to 6th most common cancer that we see in Canada. Most of them are what we call urothelial cancer, so that would be the most common type. And this type of cancer can arise from the bladder most commonly, but it can also arise from the ureters or the inside of the kidneys called the renal pelvis. And there's a whole host of less common diseases that are found in the bladder that are types of bladder cancer as well. So in bladder cancer, the initial diagnosis is usually by cystoscopy. When they're referred to a urologist with a suspicion of bladder cancer, a scope is performed. After the cystoscopy identifies a concern for bladder cancer, we'll often order some more tests. These will include the transurethral resection, which we're going to talk about. This is the TURBT or TURBT. You'll get some urine and blood tests performed, and usually some imaging tests and X-ray tests, such as a CT scan, will be performed as well. And then this comes into the realm of localized bladder cancer. And what we mean by localized bladder cancer is bladder cancer that's confined to the bladder. It essentially has not spread to other parts of the body. And we define this as muscle invasive or non-muscle invasive. And we kind of draw a line in the sand of how we deal with these in terms of, has it gone into the second deep layer of the bladder called the muscle, or has it not gone into that yet? And we treat them differently. So how do we treat localized bladder cancer or bladder cancer that hasn't spread anywhere else yet? Well, broadly, for non-muscle invasive bladder cancer, we use TURBT, and sometimes that resection that we're going to talk about is all that's needed. Sometimes we use what's called, after the TURBT, something called intravesical therapy. That's a fancy word, but it just means putting medications into the bladder. And then we use bladder removal in select cases, but we try to avoid it in non-muscle invasive disease if we can. Muscle invasive disease is different. Once it's gone into the bladder, we unfortunately have to use some more maybe invasive or advanced treatments, and that can involve bladder removal with or without the use of chemotherapy that Dr. Wood's going to talk about. We can use chemotherapy combined with radiation, or in some cases we use radiation alone. So TURBT, so this would be a common first step for many patients with bladder cancer. It's an acronym that means transurethral resection of the bladder tumor. And essentially what it means is that there's a procedure performed where you place a scope in the bladder, either under an anesthetic or under a epidural or a spinal, and then we remove the bladder tumor with a scope. It's usually the first step in the diagnosis and treatment of bladder cancers, and in certain cases, it can be the only treatment that's needed. And so this is just kind of a picture of that, what we call the resectoscope, which is the scope that can scrape it off, being inserted into the bladder to remove the tumor. So what are the side effects of TURBT? Well, the common ones would be things like bladder infection, bleeding or blood in the urine, bladder symptoms. That would include things like peeing too often or frequent, and burning with urination. In less common cases, you can have bladder injuries. It is common to have discomfort from the procedure or catheter. We usually try to give medications to help with that. And although this isn't necessarily a complication or side effect, there's often the need for repeat procedures for various reasons. So in terms of bleeding after TURBT, it's actually very common to have red urine for the first couple of days. It usually will go away on its own without any intervention needed. In addition to that, about 2 to 3 weeks after, it's common to have what we call a second bleed. So you have the first couple of days of red urine, and then everything clears up and the urine is clear or yellow again. And then about 2 to 3 weeks later, you'll get this second bleed where the urine turns red for another couple of days. That usually will go on its away on its own as well. We describe that as essentially the scab falling off the bladder, and underneath that scab there is some blood or some small blood vessels, and they have the tendency to provide some red urine again after that. So that's a common thing. Severe bleeding, which would involve filling the bladder with blood clots, making it difficult to urinate, is less common. It does happen for sure, and usually that involves a trip back to the hospital for the clots to be removed with a catheter or a procedure. I put repeat TURBT here because this is something that we commonly get asked, and we get, well, why are we doing a repeat procedure? And it's actually very common, and actually it's not just something that we do sometimes, but it's actually recommended in certain cases. So if you have a stage 1 cancer or what's called a T1 cancer, it's actually recommended in every case to repeat the procedure, even if you think you did a very good job and it's all gone on the first time. We're recommended to repeat it with the goal of making sure you're correct on that stage and that it's not a higher stage, and making sure that you've got as much of the tumor as you can, and hopefully all of it if that's possible. So that's a common thing. Things like infections in the bladder after TURBT are common as well. They usually present with burning when you're peeing more frequently, and they're often treated with antibiotics, and in rare cases need for hospitalization. Intravesical therapy, so that's medications going into the bladder. This is a common thing for patients with non-muscle invasive bladder cancer to receive. It's very effective in many cases. Essentially, you place a catheter in the bladder and medications are delivered. The most common one that we use is something called BCG. We also use chemotherapy in select cases as well. That means chemotherapy not through the IV, but chemotherapy put into the bladder through the catheter. And so BCG therapy, this is a medication that's placed in the bladder, and the purpose of this is actually to teach your immune system to fight cancers in the bladder. It is an old tuberculosis vaccine. It was actually studied in Kingston, Ontario, and discovered to work against bladder cancers. And to this day, it is one of the most effective ways to prevent and treat non-muscle invasive bladder cancers. It's often given over a series of weeks. So you end up with 6 weeks to start with a weekly treatment. And then after that, you may get what we call maintenance, or it is essentially 3 treatments at various intervals. What are the side effects of BCG? Well, there is some discomfort to the procedure. It requires a catheter going in. It's very common to get bladder symptoms. This can include burning and then peeing more often or frequently or urgently. Fever can happen. It's usually a mild fever. We usually see fevers up to maybe 38 or 38.5 at the most. We don't often see very high fevers, but it is common to get a fever. Bladder infection, because we are placing a catheter, bladder infection can come up. And in less common cases, you can actually get some scar tissue formation in the urinary tract, which is called granulomas. And they show up as little bumps, either in the bladder and urethra in women, or the bladder and prostate and urethra and in men. In rare cases, you can actually get an infection from the vaccine, essentially similar to what a tuberculosis infection would be throughout the body. This is quite uncommon. I think in my career, I've seen this once. So this is something where all urologists are trained to deal with, but not something that we see commonly. So side effects with BCG are individual. So some individuals experience worse symptoms than others. And one of the things about BCG is the more treatment you receive, the more bothersome the side effects. And I think of that as like when you get your flu shot and your arm is sore for a couple of days. And then if you go get a flu shot the next year, it might be even a little bit more sore. It's essentially boosting you. Every time you get BCG, your immune system is more and more active. And so the more BCG you receive, the more bothersome the side effects can become. There's a lot of different strategies that your urologist can use to treat or prevent these side effects. So what can we do? Well, if patients are getting very bothered by things like fever or burning around the time of BCG, we'll often recommend that they take acetaminophen, which is like Tylenol, or ibuprofen, which is like Advil. We take those medications, or both those medications, around the time of BCG. Sometimes I'll tell people to start it the morning they're coming in, and then take it for a couple of days around the clock, as described on the bottle, to help with those symptoms. We can use bladder relaxing medications. You can ask your urologist about this. There's a whole host of medications that we have that can relax the bladder and lead to less frequent urination and spasms in the bladder and discomfort. One of the things that I do if patients are having trouble with BCG is actually decrease the dose, or half the dose. And that is something we can do as well. Red flag, so these are the reasons you would go right to the hospital, the emergency room: a very high fever, so a fever in the high 38, above 38.5 or 39, significant pain, or if it's difficulty urinating. What about radical cystectomy, or removal of the bladder? So this is a big surgery. This is usually reserved for muscle invasive cancer, or in some cases with high risk non-muscle invasive disease. It often includes the surrounding organs, prostate, the uterus, and things like that. Not always, but often. And you have to allow a way to urinate. So that's what we call a diversion, and that's an ileal conduit, a neobladder, or in less common cases, something called an Indiana pouch. And so that's kind of an ileal conduit is our most common diversion. That's with an ostomy or a bag on the side. An Indiana pouch is where you actually place a little button on the skin and you catheterize it through the skin. And then a neobladder is when you essentially, neobladder means new bladder, is when you rebuild a bladder out of bowel and reconnect it to the urethra. What are the side effects? So I break down side effects of cystectomy into side effects or complications that happen during the surgery, side effects that happen early after surgery, and side effects that happen down the road or long term. So during the surgery, you can have bleeding, sometimes needing blood transfusions. I list that as common. We actually see this in about 1 in 4 patients will need a blood transfusion either during the surgery or after their surgery. Injury to surrounding organs and tissues, things like the rectum or a bowel, those are not common. They do happen, but they're not common. And then problems with the heart and lungs or brain, things like a heart attack or stroke or blood clot, having that happen during the surgery is actually quite rare. What things can happen early after surgery? Well, there can be bleeding that can happen in what we call a delayed fashion or after the surgery. Infection is probably one of our more common ones. Those can be minor infections like minor kidney infections or wound infections, or they can be severe infections like abscesses or collections of infection. Wound breakdowns can happen. The most common thing that we actually see is a slow return of bowel movement, so difficulty in getting bowel movement started again. That's got a word called an ileus. Weakness and fatigue, it's hard on the body to have a big surgery and then laying in bed for a few days afterwards can be hard. Again, heart, lung, and brain problems or problems with, like, those are heart attacks and strokes, or bowel or urine connection leaks or breakdowns. I list these as red because these are probably our more severe complications. The heart attacks and strokes we know can be severe, but the bowel and urine connection leaks or breakdowns can lead to repeat procedures or surgeries. Those are uncommon complications, but they do arise. So they're the more severe ones, but the ones that are less common. And then your long-term issues. These are things like scar tissue formation at the urinary connections that we make. So we have to connect the kidneys into the bowel with the ureters, and those can scar off and require procedures to fix that. There's mental health aspects of having the surgery: anxiety, depression, body image changes, sexual dysfunction, hernia formation, that's like developing a bulge in the wounds. Infections can happen later, such as kidney infections. And then specific to ileal conduit, you can have bag leakages or other ostomy issues with the stoma or the bag on the side. And specific to neobladders, things like incontinence or leakage, or actually having difficulty urinating, both of those things can arise. Well, how do we manage the side effects of cystectomy? It depends on the specific issue. It's everything is unique. Our best management is prevention. So we do a lot of things in patients after surgery to prevent things like bowel issues or infections or things like that. And that definitely is our best management. It often takes a team approach. So we have your primary surgeon, other specialist physicians, your family doctor, nursing, pharmacists, mental health experts, and patient support groups like Bladder Cancer Canada. So all of our bladder cancer treatments have potential side effects and complications, but generally, I think with good communication, diligence, and teamwork, we can successfully manage these issues. And it takes a heightened level of awareness to recognize these things and experience with managing them. And so, again, if you're experiencing major concerns, speak with your doctor. There's often things that we can do to help with these side effects. And with that, I'll leave the questions and comments to the end. Because I think we got a couple, we have two more excellent talks to go. But at the end, I'd be happy to answer anything that comes up.
Great. Thank you so much, Dr. Mason. So feel free, if you already have some questions coming to mind, you can put them in the Q&A now. We'll save them for later, but we will pass it over to you, Dr. Chung.
Well, thank you so much, Teresa and Bladder Cancer Canada for the invitation to speak tonight. And thank you, everyone, for taking the time out of your evening. So my task was to talk essentially about radiation therapy in bladder cancer. And I'm really just kind of going to concentrate on the role of radiotherapy in primary bladder cancer, localized bladder cancer, and specifically what we call muscle invasive bladder cancer. So my background is I'm a radiation oncologist, so I see and treat patients with GU malignancies, and one of my hot topics, as it were, is bladder cancer, and I come from a sort of a long history of actually, you can tell by my accent that I actually am not originally from Canada. I actually hail from the UK, and that's where I actually did my oncology training. And in the UK, the system there is that you train in both radiation oncology and medical oncology. So, and then when I came to Canada, I actually gave up the medical oncology part and just carried on with the radiation oncology part. So just a brief overview of what I'm going to talk about. Mostly, we're going to talk about sort of indications for radiotherapy, because it's not just in the localized setting, which I'm going to spend most of the time talking about. And then what does actually radiotherapy entail, and how do we get to the point of delivering, and how do we deal with side effects of the treatment, both short and long term? So as you've already seen, there are various what we call stages of bladder cancer, and indications for radiotherapy are three mainfold. It's very uncommon or relatively uncommon to use radiotherapy in the situation where there is so-called superficial bladder cancer, i.e. it's not actually invaded into the muscle, but we do occasionally use it, and particularly for the substance that was talked about, mostly about BCG, that has failed to control superficial bladder cancer. So we do occasionally use it in that setting. And then the other end of the spectrum is in the setting where cancer is much more advanced. It's spread in other places, maybe into lymph nodes, or the lung, or the liver, or the bone. And in that situation, it's much more likely that radiotherapy will use what we call palliatively, i.e. to treat symptoms and try to improve the symptom of patients who have locally advanced or more distant disease. And then the main topic here is that we generally use radiotherapy mostly in the muscle invasive settings. So anything that is from the T2, so this is muscle invasion here, and T3 is going slightly outside or somewhat outside of the bladder. Very occasionally we use T4, but predominantly the many patients that we would potentially treat would be those in the T2 category, and also in some of the C3 categories. And all of the other patients, if it's feasible to do surgery, we usually recommend surgery in that setting. So what about radiotherapy in muscle invasive bladder cancer? So first thing to say is that it's not really for everyone, whereas by and large, most patients who are eligible for a surgery, a radical cystectomy to remove the bladder, generally speaking, can do so. Whereas for radiotherapy, it tends to be more of a situation where we need to pick and choose those individuals who are more likely to benefit from radiation, i.e. They're going to actually have a good outcome with good local control. And if you select the inverted commas right patient, then you usually get a pretty good outcome. First and foremost is really that a baseline before any treatment starts, the pre-bladder function is a good function. If one's bladder is not really performing very well, then there may be relatively little point in trying to preserve it and not going to surgery. The second point is that individuals with smaller tumors, so in the order of 5 to 7 centimeters or less, preferably, are better candidates than patients who have got bigger tumors. It also helps if you have a solitary tumor as opposed to multiple tumors. And then this pre-invasive disease called carcinoma in situ, which the invasive cancer starts from, if it's very extensive within the bladder, we don't usually recommend radiotherapy in that setting. Some tumors occur around about the insertion of the ureter, which is the tube that carries urine from the kidney into the bladder, and they sometimes block the ureter and thereby also block the kidney. And that usually is because the tumor surrounds the ureter itself and can cause even a very, very tight stricture of the region there, which even if somebody responds very well, they don't actually open up again. So the kidney can potentially can be blocked permanently. So in that setting, because it's often more advanced disease, we don't usually recommend radiation if it's relatively severe blockage. And then the one feature that we've learned about in the last 20 plus years is that if we add either chemotherapy or more recently, something called carbogen gas to the radiotherapy, it actually leads to better outcomes. You get better responses, and you also get better local control of the tumor in the bladder. There's also a requirement for ongoing commitment for essentially lifelong bladder follow-up, because if your bladder is still there, you are potentially at risk of having recurrences in the bladder. So therefore, most patients will go on cystoscopy, most likely lifelong, more frequently at the beginning than towards the latter part of after things have been relatively clear. So what does radiotherapy look like? So this is a CT scan of a plan of radiotherapy, and I've tried to simplify this as much as possible. This is an area where the tumor is bare. This little white stuff there is just representing something called a marker that tells us essentially where the tumor is. And the area that we're trying to give the most dose to is really the tumor-bearing area. The rest of the bladder is relatively clear, but we still end up giving a little bit of radiation dose there as well. So we aim to treat the lymph nodes as well as the bladder itself. And this is the type of machine that we often use. It's called a linear accelerator. This head moves around, the patient lies there. And basically, these days, the machine does almost a full 360 around the body of the patient, never touching them. And the X-rays are through this part here, which is the head of the LINAC machine. And commonly, most patients will have either 4 or 6.5 weeks of radiation. There's mostly these two different schedules. This is obviously more convenient because it's done over a shorter period of time. This is a bit less convenient, but this probably has a much longer history, particularly in North America. But those are both options. And generally speaking, we tend to deliver on working days only, Monday through Friday. And by and large, it takes usually about 15 to 20 minutes to actually deliver the whole treatment. The so-called beam on time, when the machine is actually beaming the X-rays into the patient, is actually usually about less than 5 minutes. So there's radiosensitization that I mentioned earlier on. So we can either use chemotherapy, usually in the form of various drugs such as cisplatin, mitomycin C, and 5-fluorouracil, or gemcitabine. These are usually either given either weekly or at the beginning and towards the end of the 4 to 6.5 weeks. This is very well established. And in fact, the first study looking at radiosensitization using cisplatin was actually done in Canada by the NCIC, or National Cancer Institute of Canada, as it was back in the early to mid 90s. And then more recently, in the last 10 years or so, or perhaps a little bit more, this regimen known as BCON has become popularized mostly in the UK, but it's gaining some popularity both in Australasia and in North America and Europe. And this is actually inhaling carbogen gas, which is 98% oxygen and 2% carbon dioxide. And you also, at the same time, take these things called nicotinamide tablets, which is actually a relatively high dose of vitamin B3. And this was the first patient we treated at the Princess Margaret Hospital back in October 2022. This is the carbogen gas tank, and the patient sitting there with the team. So it takes an army to help treat a patient, at least certainly when it's something a bit novel and a bit new to us. So side effects. So these are divided mostly into either acute side effects, and these are defined as during the time of the radiation and within 3 months after finishing radiation. Commonly, they are related to where the X-rays traverse. So obviously, the bladder is being traversed with the X-rays, either the bowel, and then more general side effects such as fatigue or tiredness. Most of these symptoms tend to be fairly mild, so there's frequency, maybe some burning on peeing, some urgency, and occasionally blood in the urine, loose bowel or even diarrhea, urgency or stool, even some blood in the stool occasionally. And then less common or uncommon are skin changes. So this so-called, sometimes people will come and they say, oh, I'm going to get burnt by the radiation. But that really occurred when linear accelerators weren't available. This was sort of 50, 60 years back when the X-ray machines were very rudimentary. Nausea, vomiting, and low blood counts can also be other side effects related to radiation, but they're relatively uncommon. And then there's late side effects, which usually occur after the acute side effects have settled down, and by definition, usually occur at an interval of greater than 6 months after the radiation is completed. And again, very similar symptoms, but the reason for the symptoms this time around is, for example, bladder symptoms. Frequency is due to a small bladder because sometimes the bladder can shrink over time. Incontinence is uncommon, so if you're not incontinent to start off with, it's unlikely that the radiation will cause you incontinence. And then one can also get some blood in the urine, a condition known as radiation cystitis, where there's scarring in the bladder caused by the radiation, which can bleed on minor trauma. Bowel symptoms often are irregular bowels, occasionally blood in the stool, a condition known as radiation proctitis, and something that occurs in the bladder can also occur in the bowel. So, and these are usually not severe, and severe side effects associated with these types of symptoms in general are less than 5% or so. And then in men, there is a possibility of erectile difficulties, erectile dysfunction. It tends to be uncommon if there are no pre-existing symptoms, and tends to be more common if this is already a pre-existing symptom before the radiation. How do we treat it? Well, in the acute setting for bladder symptoms, most of the time we just increase water, reduce irritants in the diet and drinking, so reduce spices and coffee to try to minimize the amount of irritation the bladder gets. With bowels, we tend to advise patients to reduce their fiber intake. We use anti-diarrhea medication. If they're particularly tired or fatigued, then we advise rest if needed. Most of these symptoms tend to settle down usually around about 4 to 6 weeks after the radiation is done. And for the majority of people, by about 3 months after the radiation is done, they're more or less back to normal. And then in terms of late side effects, bladder symptoms, so sometimes we use medication to help with the irritated bladder symptoms or reduced capacity of the bladder. Laser treatment for bleeding, hyperbaric oxygen, which is in literally you sit in a hyperbaric chamber for many treatments in order to reduce bleeding if it's severe enough that's warranted. In terms of bowels, medications to regulate the bowels, again, laser treatment, and again, hyperbaric oxygen. And then for erectile difficulties, medication. I just wanted to show you this because although we sort of talk about a lot of side effects related, a lot of the side effects that we described are described by the patients or the caregivers or the healthcare team. And this is just some data from the BC 2000. So this is Bladder Cancer 2001 study, which was actually looking at radiotherapy with mitomycin and 5-FU, a couple of those chemotherapy agents. And this study got patients to actually complete quality of life questionnaire. So this is the bladder quality of life questionnaire and the overall quality of life questionnaire. So the important thing, I don't expect you to remember all of this, but the important thing about this is that with radiotherapy, what tends to happen is if this is baseline, there is definitely a drop in the quality of life. for all of these instruments that are used to kind of measure the quality of life in patients. And these are all patient completed. So this is the real truth, as it were, in terms of what patients feel. But as you can see, by about the 6-month mark, many or most patients are actually more or less getting back towards their baseline. So 0 is the baseline. So if you follow this line out, there's some fluctuations up and down over the course of time in terms of follow-up over 5 years here, but you can see that it mirrors the baseline. So what this by and large tells us is that the quality of life for most patients who have radiotherapy tends to mirror what they were at baseline. And these little bars here are what we call the confidence intervals, which estimates what the statistical error is in terms of the estimation of the change from baseline and whether these are in fact real. And as long as the confidence intervals overlap this baseline line, this little dotted line here, it usually means that within the error of estimate, that essentially the quality of life remains, apart from the initial dip, comes back to more or less normal with longer follow-up. And with that, I will conclude and hand over to Dr. Wood.
Welcome, everybody. It looks like we've got literally across the country joining us. So I apologize to our Quebec participants. My French is horrible, so I won't even try. And shout out to somebody from Neepawa. My family is from Carberry, so just down the road. So I'm going to talk about systemic therapy, toxicity and side effects. And I noticed somebody left us thinking it was just all about BCG. So we tried to cover all the topics and hopefully reach people at different stages and points in their bladder cancer journey. Next slide, please. These are just my disclosures. So I do research and advisory boards with different companies, but I don't have any personal financial compensation from any of them. Go ahead, please. So what I do as a genitourinary oncologist is the same as Ross in terms of the tumor types, but what I do is give systemic therapy. And so that may include supportive care alone, meaning managing symptoms such as nausea, discomfort, and so forth, chemotherapy, immunotherapy, targeted therapy, and hormone therapy. So those last 4 bullets all together are considered systemic therapy because they go in your body and should hopefully work everywhere. Hormone therapy is not used in bladder cancer. It is in others like prostate and breast most commonly. Next, please. So again, Ross touched on this. And again, just to say that you all know that are on this line that it's a common cancer and we need to do more and more research in this area. Next slide. And again, I'm going to talk mostly about urothelial bladder cancer from now on. And this slide isn't for you to memorize, but only just to say there are lots of different options. And this is for localized. So there's surgery, there's a concept of called neoadjuvant chemo. And what that means is you're giving it before the definitive treatment, which would either be surgery or radiation. You may or may not get immunotherapy after, depending on the pathology. You could do surgery first and then adjuvant therapy. So that term adjuvant means there's some higher risk features that make a person at higher risk of it coming back. So sometimes we'll give chemotherapy or immunotherapy in those situations. As Peter just mentioned, we can give chemo with radiation, and we may sometimes give chemo even before, sometimes radiation alone, sometimes chemo alone. Next, please. For metastatic disease, the big categories that we talked about in terms of chemo, kind of think our traditional chemo, which I'll talk about in a sec. And then there's this concept called antibody drug conjugates. So just keep that in the back of your mind. And then we talked about the immunotherapy and targeted therapy. And the things you also have to remember, sometimes we give treatments together, and that's concurrent, and sometimes we give them in sequence, and that's called sequential. Thank you. Next slide. And so chemo is the little picture up in that corner is from biology in grade 10, if you remember. You've got a cell, and your DNA and chromosomes have to duplicate and make 2 copies, and then that divides, and you form 2 cells from 1. So that happens over and over in cancer. And so chemo affects cells that are dividing by hitting different parts of this mitosis or replication. And we'll often use combination of drugs that work differently on this replication process. So one may be the DNA, one may be as those 2 cells are separating, trying to stop that. So different mechanisms to try to stop the cells from dividing. And because of that, side effects are common in cells that have a higher turnover rate. And that's the bone marrow. And so that's why you can have your white count, your hemoglobin, your platelets affected. your hair, so that's why some chemo causes hair loss, not all, and the moist surfaces. So example, your mouth, those cells in there actually replicate fairly quickly, so that could be a side effect. Side effects with chemo are fairly well known because the drugs have been around for a long time. We kind of know the timing of when they're going to happen, so we can really educate patients well about it and hopefully manage symptoms. Next slide. And for bladder cancer, the two common drugs are called gemcitabine and cisplatin, and then the other is an abbreviation called MVAC, and it's a combination of those 4 drugs. Sometimes we have to use cisplatinum's cousin called carboplatin, because cisplatin, which is our best drug out there for bladder cancer, can cause kidney problems, numbness of the fingertips and toes. So that's a problem if you've got pre-existing neuropathy, which many diabetics do, for example. Ototoxicity, so it can decrease hearing, although not normal conversation hearing. It tends to be much higher frequency. So if you're communicating with dogs, that's where it may be more of a factor, or ringing of the ears. It can cause fatigue and it can cause more nausea, but we've got very good treatments for nausea. So that should never, ever, ever be a concern for patients. We should always be able to address that. Next slide. And so this is kind of a new type of chemo. It's called antibody drug conjugate. So it's a tumor targeting antibody attached to a chemo drug. So essentially you've got your chemo drug, but you've got this other molecule attached that's supposed to target specifically to bladder cancer. Next slide. So this is one example called enfortumab vedotin, and I apologize that all of our new drugs have just crazy names, so they're crazy for me too. So we abbreviate this EV, but the antibody is something called Nectin-4, and bladder cancers express Nectin-4. And then the little green dot is the chemo drug. So it binds to the cancer cell, moves into the cell, and then releases that little green chemo drug, and hopefully results in cell death. And we know we know exactly how that chemo drug works. It cannot be used alone because of toxicity, but when it's trying to target specific cancer cells, it seems to be able to be tolerated. There's others coming on board as well. This is just one example. Next slide, please. The side effects of it, again, can be neuropathy. So one of the problems is if you get neuropathy from your first line, it may limit what you can use afterwards. Unfortunately, Nectin-4 is also expressed in skin. So people can get skin reactions and skin rashes because the drug wants to go to the skin as well. Your sugar can go up. You can get some eye symptoms. During the actual infusion, you can have a reaction. And it is a chemo drug, so it can lower your blood counts just like almost all chemotherapy can. Next slide, please. The next kind of group of treatment is called targeted therapy. And how I describe it to patients is you can think of cancer as a seed in the soil, and chemo affects the seed. So it's going to hopefully kill that seed. Targeted therapy affects the soil around the seed so that the seed or the cancer cells can't grow. And the other analogy I use is think of a big road going into a city. And for some cancers, we know the major road going into that city. So we're going to give a drug that blocks that road so that the cancer cells can't get the nutrients, or you can't drive into that city. So it's kind of 2 different ways to think about it. Next slide. In bladder cancer, that road going into the cancer cell or the city is called FGFR, fibroblast growth factor receptor. So we know in some studies up to 20% of bladder cancers have this, and up to 40% of upper tract, that ureter and renal pelvis, have it. Now, in real life, the numbers aren't quite that high. Certainly in Nova Scotia, we haven't seen that high. And so this is a pill that blocks that pathway. So on that diagram on the far right, you can see that little thing that says FGFR. So we're going to block that pathway so that all the activities in the cell that pathway is supposed to help drive, meaning promoting cell growth and cancer growth and things like that, we're going to block that. And so this is a pill that we are allowed to use if the chemotherapy stops working, provided you have this marker on your cancer cells. So we can actually ask the pathologist to go back to your bladder tissue or your TURBT tissue and analyze it to see if you've got this mutation. And if you don't have it, the treatment's not going to help. Next slide, please. The side effects are a little bit similar but unusual. You can again have some weird skin rashes with it. You can get a sore mouth. It can elevate your phosphorus and lower your sodium, so we have to watch the electrolytes. That's just a blood test. And again, you can have eye problems. So we get people to see ophthalmology regularly to keep an eye on that for us. Next slide. And then immunotherapy is basically trying to stimulate your own immune system to fight the cancer. And it's basically trying to turn the immune system on, kind of like the BCG that Dr. Mason talked about initially. And there are many, many different types of immunotherapy, including BCG. In bladder cancer, the category is called immune checkpoint inhibitors. Next slide. And so if you look at that red thing, that's your cancer cell. And if you look at surgery, radiation, chemo, targeted therapy, they're working on the tumor cell. But with the immunotherapy, we're working on the green cells, which is your own immune system to go and fight the cancer. So it's quite different than the other therapies that we've talked about so far. Next slide. And so in bladder cancer, we can use it in localized bladder cancer after surgery if there's certain pathological features. And I'm just putting a couple names out there for people that are on drugs like these, so you recognize the names. The drug is called nivolumab. And again, we usually abbreviate all these drugs by the first two syllables, so we call it Nivo. It's monthly for a year. If the cancer is spread and you've had a good response to initial chemo, sometimes we'll use a drug called avelumab. It's every 2 weeks. And if the chemo didn't work or stopped working, sometimes we'll use pembrolizumab or Pembro every 3 weeks. So you can see that there are different drug companies make these drugs, and they have different frequencies and different durations. Okay, next slide, please. In terms of side effects, this is a picture of your body. And essentially what I tell patients is because we're trying to stimulate the immune system, you can get inflammation of any tissue in your body. Common ones are skin, lungs, bowel, and then the liver, which would pick up in the blood, and the endocrine organs like the thyroid or the adrenal glands. But you have to go into it knowing it can be anything. And the people that are at higher risk of immune therapy side effects are those that already have an autoimmune disease. And an autoimmune disease is things like Crohn's disease, multiple sclerosis, rheumatoid arthritis. Those are all diseases where your body is kind of attacking itself to start with. And so the side effects with this are less predictable than with chemo in terms of both timing and severity. If you look at studies that can compare chemo to immunotherapy, the quality of life is better with immunotherapy, and that's because the majority don't get a bad side effect. But if you do get a side effect, it can be quite bad, and we have to try to turn off the immune system, and that's with other drugs to dampen down that immune response. Next slide, please. And so to kind of summarize, chemo, it's very well studied. Most people have some, fairly predictable, and we manage it by either holding the drug or decreasing the dose. Immunotherapy, many people get none at all, and they say, "Are you sure you're giving me drug, Lori?" They're a bit more unpredictable. They can be quite severe. And again, you have to turn off the immune system to try to stop them. And the problem is you don't know ahead of time with any of these treatments who it's going to work in, and you don't know ahead of time who's going to have the side effect. And we know that's frustrating for you as patients and family members. Hopefully one day we're there in a better place and we'll know ahead of time which drug works in which person. Next slide, please. So things that we have to think of as doctors are how fit is the person to start with. So if you have a lot of numbness and tingling in your fingertips to start with, I probably can't use that drug that would cause it. What other pre-existing medical problems? Is somebody already on high doses of steroids for another reason, for example? We have to think the more drug you get, the worse the side effects can get, just as Dr. Mason mentioned with the BCG, the same can be with cisplatin. And we have to think of overlapping side effects. If you're getting both radiation and chemo together, what's that going to do? Sometimes the side effects can actually happen after the treatment's finished, so we have to keep an eye on you after. And then obviously the biggest thing are what are the goals and values of any one patient or person, and discussing all of the benefits of treatment and the potential side effects, and trying to decide what any one person wants to do. And sometimes when we're running really late in clinic, it's because we're spending a lot of time on this. And so we apologize as medical oncologists ahead of time. Next slide, please. So for the future, the good thing is there's always ongoing research. And so just recently, there was a big announcement of the results of a study that looked like that drug antibody conjugate I mentioned, and enfortumab vedotin combined with immunotherapy may actually be better than what we're using right now. So that's exciting. We're looking at ways to decrease side effects. We're always learning something new in bladder cancer, and our goal is always to help improve patient care and patient outcomes. Next slide. And so obviously you're all members of Bladder Cancer Canada, you wouldn't be here, and they're a great resource for patients and their families to help deal with, some treatment decisions, but also side effects, support advocacy and education. Next slide, please. And if anybody hasn't seen, they've got a lot of educational material. So this is one we use regularly in clinic, all of us. And so kind of going through educating people on what bladder cancer is, where it involved, and those sorts of things. Next slide, please. And I'll leave it with a lighthouse. That is Peggy's Cove for anybody that hasn't been. And if you haven't been to Halifax to see it, come on. And I'll leave it at that. Hopefully I finished on time.
Yes, absolutely. Thank you so much. What a jam-packed session we've had tonight. Thank you so much for covering all of these important topics for our community. So we will launch into the questions. I see, Dr. Mason, you answered a lot in the Q&A, which is great because we're getting a little short on time, but let's see what we've got. So a male patient experiencing low hemoglobin and magnesium after treatment, which included 4 cycles of chemotherapy. He has had 3 separate blood transfusions, magnesium added to his chemo, and he eats healthy. Is there anything else he can do to help these side effects?
Yeah, and so I'm gathering the chemo had cisplatin in it. So one of the side effects of cisplatin on the kidneys is you can lose both potassium and magnesium. So usually oral magnesium replacements do work. One of the side effects of that is diarrhea. Some people get none, some people get a lot. There's also a lot of foods that contain magnesium. So I have a regular handout that I give to patients to try to increase it in the diet. In terms of the blood transfusions, some people's bone marrows are definitely hit harder. Some people come into chemo already anemic. Again, I missed whether there was surgery prior to the chemo, but some people come into chemo already anemic because of either metastatic disease or post-op, and we do end up having to give transfusions. So there's nothing you can do other than just double check with your doctor that they don't think you've got an iron, B12, or folate deficiency. And if you don't, then just keep doing what you're doing.
Okay, great. Thank you. A female patient who underwent a cystectomy in 2018 is experiencing abdominal pain. She recently had a colonoscopy and the GI doctor said there's a lot of scar tissue. So she had a kind of 3-part question. Is that common? Is there anything she can do barring surgery? And how does scar tissue affect the natural function of a bowel?
Yeah, good question. So scar tissue formation is a common problem. It usually happens after every surgery that you have. We call them adhesions, which is just essentially your body on the inside heals in different ways and heals to itself. For bowel problems, the only real things we can do are making sure that the bowel is moving regularly, fiber and fluids, and sometimes stool softeners or the over-the-counter Restorelax is a common thing that we use that's quite safe and safe to use. Honestly, most of the time surgery doesn't actually help because you end up reforming the scar tissue again. It works in the short term, but in the long term it doesn't. So yeah, fiber fluids and sometimes stool softeners.
Perfect, thank you. Female patient in the first year of a 3-year BCG treatment plan. She's experiencing a lot of burning discomfort since the first day of treatment. She's doing warm baths and Tylenol. I know you quickly mentioned this, Dr. Mason, but is there anything else you would recommend?
Yeah, definitely. So speak with your doctor about this, but just some things that we do use. We use exactly what you said, the so-called sitz baths, Tylenol. If Advil is safe for you, then using Advil can help with the inflammation. And then there's a whole host of bladder-specific medications that can relax the bladder. There's ones that actually cause you to pee less frequently, and there's 2 classes of those medications. And there's actually an oral medication you can take that causes the almost like an anesthetic to the bladder itself, and your doctor will kind of be familiar with all those. So there are definitely things that can be done with that.
Great, thank you. A female patient following 10 BCG treatments experienced pain and increased urination, no longer getting the BCG treatments, but still experiencing the urgency, sometimes 4 to 8 times per night. Anything she can do?
Yeah, so the first thing we do is again, trying to make sure we avoid any bladder irritants. So those would be, is there any foods, caffeine, alcohol, things that would irritate the bladder? But aside from that, it would really be conservative. And one of the things is that it usually doesn't go away. It can often take weeks and sometimes months, but it usually will go away as we get away from BCG. But there are bladder-specific relaxant medications. The common one we use that's safe is something called mirabegron, which is a medication that relaxes the bladder and is safe in almost everyone. So something to ask your doctor about.
Okay, great. I see we're getting close to time, so maybe we'll do 1 or 2 more. After 2 years of treatment, including bladder removal and radiation, when the cancer spread, I'm receiving immunotherapy. This resulted in massive back pain, need to take Tylenol 6 times, Tylenol 3 6 times a day. Is this normal, and will I need to continue this for the rest of my life?
Yes, so back pain or pain is not a usual side effect of immunotherapy unless it's related. I'm just trying to think of what situations it would be related to. So pain isn't. You don't normally get inflammation of the bones. You can get a myositis, inflammation of the muscles or something like that, but you should have tenderness when you actually squeeze your muscles and things, and there's an actual fairly easy couple blood tests to check for that. So it's not a common side effect with immunotherapy. I'm assuming you've brought it up with your physicians and things, but it's something to definitely bring up with the team. It's not common.
Okay, great. Thank you. And last question, which is a 2-parter. Is it common for checkpoint inhibitors to be used instead of chemotherapy? And is it common to continue immunotherapy treatments following a radical cystectomy?
So it completely depends on the pathology and whether the patient is a candidate for chemotherapy. So if we see people that didn't have chemotherapy prior to a cystectomy, then we'll see them after. And if they can get chemo, we still would give chemotherapy. If they can't get chemotherapy, then we'll discuss immunotherapy, but you have to meet the criteria, the same criteria that would have been studied in the trial. So that depends all on certain pathological findings. So the urologist should be aware of those pathological findings. If for any reason they're not, the medical oncologist would be, but most urologists would know who to refer on.
Okay.
So it really depends on that. And I'm just typing a question to somebody, or a same question, so I'll try to finish that before we go off in
Yes.
to go.
Okay, perfect. Well, thank you so much, Doctors Wood, Mason, and Chung. This was a really great session, and I know really valuable for our community. I am recording the session, so we will put it up online. I know there was a lot of information, and I will also copy the Q&A questions and answers to share that with a copy of the recording, just so everyone has those. I know there were some questions around that. So we hope you enjoyed this session. Next month, we will release information on navigating the disability tax credit with Rosemary Hill. In March, we're going to do a session on urothelial upper tract carcinoma with Dr. Nathan Wong. And in April, we're hosting an in-person education event in Toronto. In the chat, Shasta is going to share a link to register for these sessions, as well as a quick feedback survey, and that will also come through email tomorrow as well. We'd love to hear your thoughts on this session, suggestions for the future, so please take a few minutes to complete this survey. And if you'd like accommodations to complete the survey, or if you have any additional comments or questions, you're always welcome to call us at 1-866-674-8889 or email info@bladdercancercanada.org. Thank you again, Doctors Mason, Chung, and Wood, for sharing this important information for us. And thanks to everyone who attended. I hope you have a great night.